Everyone to this deep dive on cholinergic drugs.
Mm-hmm.
A really crucial topic we're unpacking today, much like the discussions you find over on KMR Advise. So if you're a medical student following along there, or just anyone interested in these vital medications, you are definitely in the right place.
Absolutely.
And just a reminder, over on KMR Advise, please do like, subscribe, and hit that bell icon. It really helps us bring you more educational content like this one.
And our goal today, well, it's really to get a solid handle on these cholinergic drugs. We'll be using a comprehensive overview document as our guide.
Right.
Stick pretty close to its structure, just to make sure we cover everything clearly. Think of it like a lecture discussion format.
Exactly. So we're going to unpack their uses, how they treat different conditions, how they're classified, the nitty-gritty of how they actually work in the body.
The mechanism of action.
Yeah, exactly.
Yeah.
And what happens to them once they're in the system, potential side effects, when not to use them, how they interact with other drugs.
And those key clinical pearls, really important takeaways.
Absolutely. The kind of insights you'll find valuable on KMR Advice. So let's get started. Where does our source begin? Uses.
Yes, uses of cholinergic drugs is first up. And the first condition listed is glaucoma. The example drug is pilocarpine.
Pilocarpine.
Okay, it's described as a direct-acting agonist. So the question is, what does that mean in the context of glaucoma?
Right. So direct-acting agonist. How does that translate into helping someone with glaucoma?
Well, direct-acting means it binds directly to the receptors, like a key in a lock.
Okay.
Specifically, muscarinic receptors in the eye, the M3 subtype. This binding action triggers a response. It increases the outflow of the aqueous humor.
The fluid inside the eye.
Exactly. In glaucoma, that fluid doesn't drain properly, pressure builds up. So pilocarpine helps it drain, lowering the pressure. Simple as that, really.
Makes sense. Okay, next on the list is myasthenia gravis. The drug here is neostigmine, which is a cholinesterase inhibitor. So how does inhibiting an enzyme help with muscle weakness? That seems a bit counterintuitive at first glance.
Yeah, it does sound it. But think about how nerves talk to muscles. They release a chemical messenger, acetylcholine. In myasthenia gravis, the body attacks the receptors for acetylcholine. Fewer working receptors means muscle weakness.
Got it.
Neostigmine inhibits cholinesterase. Now, cholinesterase is the enzyme that normally breaks down acetylcholine. So by blocking that breakdown enzyme, neostigmine increases the amount of acetylcholine hanging around in the gap between the nerve and muscle.
So more messenger to hit the fewer available receptors.
Precisely. It improves the chances of the signal getting through, which boosts muscle strength. It's about amplifying the signal that's left.
Clever. Okay, then we have Alzheimer's disease. The example is donepezil, another cholinesterase inhibitor.
Yes.
So same basic principle, inhibiting the enzyme, but this time targeting the brain.
Exactly right. In Alzheimer's, you lose nerve cells in the brain that use acetylcholine for communication. This loss contributes to the memory and cognitive problems.
Right.
Donepezil inhibits acetylcholine breakdown in the brain, boosting levels in areas critical for learning and memory. It doesn't stop the disease progression, mind you.
No, it's not a cure.
Not a cure, but it can help manage the symptoms, slow down that cognitive decline for some patients. A really important point we often discuss on KMR Advice.
Definitely. Okay, moving on. Urinary retention. The drug listed is bethanical, a muscarinic agonist. How's that helping the bladder empty?
Bethanical is like pilocarpine in that it's a direct agonist, but it targets muscarinic receptors mainly in the bladder and urinary tract.
Right.
So it directly stimulates the bladder muscle to contract and at the same time tells the sphincter muscle to relax. That coordinated action helps empty the bladder.
Makes sense. And we see neostigmine pop up again, this time for postoperative ileus. What's the link there?
Yeah, so postoperative ileus is when the bowels just kind of slow down or stop moving after surgery. It's temporary usually.
Right, I've heard of that.
Neostigmine can help get things moving again. By increasing acetylcholine levels in the gut, it stimulates the smooth muscle contractions peristalsis.
It's the digestive system back online.
Pretty much, yeah. Restores that normal motility.
And the last one listed under uses is anticholinergic toxicity treated with physostigmine. How does giving a cholinergic drug fix anticholinergic toxicity?
Okay, this one feels backwards, doesn't it?
Yeah.
But it's smart pharmacology. Anticholinergic drugs block acetylcholine's effects.
Right.
Physostigmine is a cholinesterase inhibitor, like neostigmine, but crucially, it can cross the blood-brain barrier. It gets into the central nervous system.
Okay.
So by boosting acetylcholine levels in the brain, physostigmine can directly counteract the blockade caused by the anticholinergic drug, especially those CNS effects like confusion or hallucinations.
Got it. Our source also mentions some procedural uses. First, reversing neuromuscular blockade after surgery. Neostigmine is used, but combined with glycopyrrolate. Why the combo?
Yes, this is a super important clinical point, something we definitely emphasize on KMR advice. During surgery, you use neuromuscular blockers to relax muscles.
For intubation surgery access, yeah.
Exactly. Afterwards, you need to reverse that so the patient can breathe properly on their own. Neostigmine increases acetylcholine, which helps restore muscle function at the neuromuscular junction.
Okay.
But that increased acetylcholine doesn't just act on muscles. It also stimulates muscarinic receptors elsewhere, like the heart. This can cause bradycardia, a slow heart rate.
Which could be dangerous.
Very. So glycopyrrolate is an anticholinergic drug given alongside neostigmine specifically to block those unwanted muscarinic effects, especially on the heart. It keeps the heart rate stable while the neostigmine reverses the muscle relaxation.
It's a balancing act then. Block the bad, keep the good.
Precisely. You're targeting the effects.
And the other procedural use mentioned is diagnosing myasthenia gravis with edrophonium. Why a short-acting drug for diagnosis?
The edrophonium test, sometimes called the tensilon test, is all about speed. Edrophonium is a very short-acting cholinesterase inhibitor.
Okay.
So when you give it to someone you suspect has myasthenia gravis, you look for a very rapid but temporary improvement in their muscle strength. Maybe an eyelid droop gets better for a minute or two.
Confirmation.
Exactly. That brief boost suggests that, yes, increasing acetylcholine helps overcome the receptor issue typical of myasthenia. And because it's so short-acting, you don't get prolonged side effects. It's a diagnostic tool.
Okay, that clarifies the uses really well. Let's switch gears now and talk about classification. How are these drugs grouped?
Right. Our document breaks them down nicely. First, main group. Direct-acting agonists.
Like pilocarpine and bethanical we mentioned.
Exactly. They bind directly to the cholinergic receptors, mimic acetylcholine. Think pilipine for pilocarpine, maybe uracilline for bethanical. Those are some brand names you might see, even in India.
Got it. And the second group?
The indirect-acting drugs. These are the cholinesterase inhibitors. They don't bind the receptor themselves. They stop acetylcholine breakdown.
And these are split further, right? Based on duration.
Correct. You have the reversible ones. Their effect is temporary. Examples are done. Pizil, brand name, Eriseptus common, and neostigmine, often prostigmine. They block the enzyme for a limited time.
Okay. And the other type?
Irreversible cholinesterase inhibitors. Ecothiopate, brand name phospholine iodide, is the main example here. These form a very stable, long-lasting bond with the enzyme.
Much longer effect, then.
Much longer, yes.
And there was a third category mentioned, mixed action.
Yeah, Carbachol, sometimes sold as Myostat. It's called mixed action because it can actually activate both muscarinic and nicotinic receptors directly, plus it has some weak cholinesterase inhibiting activity too.
So it does a bit of everything.
Kind of, yeah. And the notes mentioned its primary use is also in glaucoma.
Okay, classification makes sense. Direct, indirect reversible, indirect irreversible, and mixed. Let's dig into the mechanism of action now. How exactly do they produce their effects?
Right, the MOA. Step 1 is receptor activation or increasing the messenger. For direct agonists like pilocarpine, it's simple. They bind the receptor. Pilocarpine hits M3 receptors in the eye, increases aqueous outflow. Done.
And the inhibitors, neostigmine, for example.
Their approach is indirect. They block the acetylcholinesterase enzyme right there in the synapse, the gap between nerves.
So the acetylcholine doesn't get broken down as fast.
Exactly. Its concentration goes up, meaning more of it is available to stimulate whatever postsynaptic receptors are. There could be muscarinic, could be nicotinic. This boosts the overall parasympathetic activity.
Okay, so receptors get activated directly or indirectly. What are the downstream clinical effects we actually see?
This brings us to the classic effects. For muscarinic stimulation, think SLA-DGE. It's a mnemonic medical students on KMR Advise should definitely know.
Right, SLAU-DGE.
Lacrimation, tears, urination, defecation, GI motility increase, and emesis, vomiting. Basically, signs the parasympathetic system is in high gear.
Okay, that's memorable. What about nicotinic effects?
Nicotinic effects are mainly seen at the neuromuscular junction. You might get muscle twitches, fasciculations.
And CNS effects. You mentioned Dunpezil works in the brain.
Yes, central nervous system effects are important. Dunpezil boosting acetylcholine in the cortex improves cognition in Alzheimer's. Other drugs, like physostigmine, crossing the blood-brain barrier, can have CNS effects too, both good and bad.
And how does the action stop? How does the body handle these drugs? Termination.
Varies a lot. The reversible inhibitors, like neostigmine, they only block the enzyme temporarily. Their effects last maybe 2 to 4 hours typically. They're broken down often by other enzymes in the plasma and excreted by the kidneys.
Relatively short-lived.
Relatively, yes. But the irreversible ones, like ecothiopate, they're often organophosphates. They form a very strong covalent bond with the enzyme.
So the enzyme is knocked out for good.
Essentially, yes, until the body can synthesize brand new enzyme molecules, so their effects can last for days or even weeks. Big difference.
Huge difference. Okay, let's talk pharmacokinetics. What the body does to the drug. Our source has a table, right? Absorption, metabolism.
Yep, a handy summary. Let's hit the highlights. Pilocarpine eye drops, onset pretty quick, 10-30 minutes. Metabolized mainly by the liver, excreted in urine.
Okay, neostigmine the Phi.
Even faster onset, maybe 5-15 minutes intravenously. Metabolized by plasma esterases, those enzymes in the blood, and also excreted via urine.
Dunpezil, taken orally for Alzheimer's.
Slower onset, takes a few hours, maybe 3 to 4. It's metabolized in the liver by specific enzymes. The CYP enzymes 3A4 and 2D6 are mentioned, then excreted in urine.
And physostigmine IV. For that anticholinergic toxicity.
Rapid onset again, 5-10 minutes. Like neostigmine, it's metabolized by those plasma esterases and cleared by the kidneys.
Good overview. The document also pulls out some clinical pearls. Practical tips? What are those?
Yeah, these are key takeaways, the kind of stuff you really need to know for practice, like we stress on KMR advice. One is that neostigmine plus glycopyrrolate combo for reversing blockade. We talked about why preventing bradycardia. Super important.
Definitely. What else?
The other one highlighted is Dunpezil's very long half-life, about 70 hours.
Wow, that's long.
It is. And what that means clinically is you can dose it just once a day. Much easier for patients, especially those with cognitive impairment, to stick to the plan. Improves adherence.
Big practical advantage.
Okay.
But no drug is without potential downsides. Let's talk adverse effects.
Right. We can group them again. Muscarinic side effects are basically too much parasympathetic stimulation. So think SLIDGE again, but as problems. Bradycardia, diarrhea, potentially bronchospasm, which is airway narrowing.
And how do you manage those?
Luckily, we have an antidote. Atropine. It blocks muscarinic receptors, counteracting those effects.
Okay, what about nicotinic adverse effects?
Overstimulation at the neuromuscular junction can paradoxically lead to muscle weakness, not strength. In severe cases, this is the cholinergic crisis we mentioned.
A dangerous one.
The dangerous one, yes. It can cause profound weakness, even paralysis of respiratory muscles, requiring ventilator support.
And CNS side effects.
Possible too. Physostigmine, getting into the brain, can sometimes trigger seizures, though rare. Dunpezil can cause insomnia in some people, probably due to that increased brain acetylcholine. Often, lowering the dose helps manage that.
Okay, so when should these drugs absolutely not be used? Contraindications.
Good question. There are absolute contraindicated situations where you generally avoid them entirely. Asthma or COPD is a big one.
Because of the bronchospasm risk.
Exactly. Also, any kind of mechanical obstruction in the GI tract or the urinary tract, increasing motility or contraction against a blockage could cause a rupture or perforation. Very dangerous.
Definitely avoid then. Any relative contraindications. Where you use caution.
Yes. Pre-existing bradycardia or heart block, you need to be very careful as these drugs can worsen it. And pregnancy specifically, ecothiopate is mentioned as having potential teratogenic risk, so it's generally avoided.
Got it. What about interactions with other drugs?
Several important ones. Acetylcholine, a muscle relaxant. If you give it with a cholinesterase inhibitor, the paralysis can last much longer.
Why is that?
Because acetylcholine is normally broken down by plasma cholinesterase, the same type of enzyme that some inhibitors block, so its breakdown is slowed.
Okay. Other interaction.
Beta blockers. They also slow the heart rate. Combine them with a cholinergic drug, and the risk of severe bradycardia goes way up.
Additive effect.
Additive effect, yes. And then, obviously, anticholinergic drugs like atropine will directly oppose or antagonize the effects of cholinergic drugs. They cancel each other out, essentially.
That makes sense. Our source also highlighted an exam tip again. physostigmine crossing the blood-brain barrier.
Absolutely critical point. That's why it's the go-to for CNS anticholinergic toxicity. Got to get into the brain to fight the effects there. Worth repeating for anyone studying, maybe watching KMR advice.
Definitely. Let's look at some more specifics on dosage, starting with neostigmine again.
Okay. For myasthenia gravis, orally, it's typically something like 15 to 30 milligrams, maybe 3 times a day. If given by IV or IM injection, the dose is much lower, maybe 0.5 to 2.5 milligrams.
And for reversing the neuromuscular blockade?
That's dosed by weight, usually 0.04 to 0.07 milligrams per kilogram. And cannot stress this enough, always give it with glycopyrrolate.
Always with glycopyrrolate. Got it. What about pilocarpine eye drops for glaucoma?
Dosage varies, usually 1 to 2 drops. The concentration can range from 1% up to 4%, and frequency is up to 4 times a day. Depends on the patient's intraocular pressure response.
Tailored to the patient.
And Dunpezil for Alzheimer's. Standard approach is start low, go slow. Begin with 5 milligrams once daily. Then, after about 4 to 6 weeks, if tolerated, increase to the usual maintenance dose of 10 milligrams once daily. That titration helps minimize side effects.
Okay. There was also a pediatric note about ecothiopate.
Yes, a warning. Avoid using ecothiopate eye drops in children if possible. There is a higher risk they could develop cataracts with long-term use compared to adults.
Good to know. Let's talk toxicity more. What are the signs of a full-blown cholinergic crisis, and what's the immediate action plan?
Cholinergic crisis is serious. It's an overdose, essentially. You'll see extreme SLUGE symptoms, profound muscle weakness, fasciculations maybe leading to paralysis, and crucially, respiratory failure.
Life-threatening.
Absolutely. Immediate action,
Yeah.
Secure the airway, provide oxygen, maybe ventilation. And pharmacologically, give atropine 5e, usually 2 milligrams initially, repeated as needed, to block the muscarinic effects, if it's organophosphate poisoning.
Like from pesticides?
Often, yes. Or nerve agents. If it's an organophosphate, you also need to give pralidoxim, or 2-PAM. Pralidoxim can actually reactivate the cholinesterase enzyme that the organophosphate irreversibly inhibited, but it needs to be given early.
So atropine for symptoms, pralidoxim for the enzyme if it's an organophosphate. What are the specific signs pointing towards organophosphate poisoning?
You look for the classic toxidrome, meiosis, pinpoint pupils, lots of sweating and salivation, muscle twitching, maybe seizures, confusion. And the management beyond atropine and pralidoxim is decontamination.
Getting it off the patient.
Crucial. Remove contaminated clothes immediately. Wash the skin thoroughly with soap and water to stop any further absorption.
Makes sense. Our document also flags some black box warnings and keynotes. What are those?
Right. Ecothiopate, we mentioned the cataract risk with long use. That's a black box warning. For Dunpezil, there's a warning about increased risk of GI bleeding, especially if the patient is also taking NSAIDs like ibuprofen.
Need to be cautious there.
Definitely. And methanyl should generally be avoided in patients with active peptic ulcer disease because it can increase stomach acid.
Okay. And one more high-yield fax was mentioned.
Yes, using the edrophonium test not just for diagnosis, but to differentiate between a myasthenic crisis and a cholinergic crisis.
How does that work again?
If the patient's weakness is due to worsening myasthenia, myasthenic crisis, giving edrophonium should cause a temporary improvement in strength. But if they're weak because of too much cholinergic medication, cholinergic crisis, edrophonium will likely make the weakness worse. Helps guide treatment.
Very useful distinction. Okay, finally, the source gives us a kind of final exam checklist. Let's quickly run through those key areas again for everyone listening, especially those following on KMR advice.
Sounds good. Key areas to lock down. First, mechanism of action. Know whether it's direct muscarinic nicotinic activation or cholinesterase inhibition. Second, key drugs and uses. Neostigmine, MG, NMB, reversal, pilocarpine glaucoma, Dunpezil, Alzheimer's. Know those core associations. Third, contraindications. Remember asthma and bowel obstruction as absolute no-goes. Fourth, antidotes. Atropine for muscarinic overload, pralidoxim for organophosphates, crucial.
Got it.
And fifth, key concepts. Understand SLUGE syndrome, know what the edrophonium test is used for, nail those, and you've got a strong foundation.
Excellent summary. So, as we wrap up this deep dive, we've really covered a lot of ground on cholinergic drugs. It's clear how diverse their applications are and how intricate their interactions within the body can be.
Absolutely. They're incredibly important tools in medicine, managing a wide spectrum of conditions.
For all of you following along, especially on KMR Advise, we really encourage you to review this material. Think about how these drugs impact different body systems. Understanding the link between mechanism, therapeutic effect, and side effect is so vital.
It really is. That deep understanding is what leads to safe and effective prescribing and patient care.
And for our final thought today, something to ponder, particularly for the medical students tuned in via KMR Advice. How might individual patient factors think? Genetics, maybe other illnesses, or the other medications they're taking? How might all that influence how effective and how safe a particular cholinergic drug is for that specific patient?
That's a great question. It highlights the move towards more personalized medicine, doesn't it? Definitely something to keep thinking about.
It is indeed. Well, if you found this detailed discussion helpful, please do remember to like, share, and subscribe to the KMR Advice channel, and hit that notification bell so you don't miss our future deep dives. Thanks so much for joining us today.